This is Lecture 10, Cardiovascular System, and we're going to begin with the heart anatomy. This is the beginning of a 3-week unit, which is the second unit of this course. Here are the learning objectives. At the end of this lecture, please return to these learning objectives to check and make sure that you've gotten everything out of this lecture that we've intended. So the cardiovascular system is a closed system where the heart acts as a double-sided pump that establishes blood pressure within pulmonary and systemic circulation. The heart then pumps the blood through the blood vessels, which act as passageways for the blood to be distributed throughout the body to exchange materials to and from the lungs and to and from the tissues. The blood is a liquid connective tissue that transports dissolved and suspended materials. The heart is a muscular organ with hollow chambers that fills with and pumps blood. It's about the size of your fist, about 200 to 350 grams, and is located at the center of the thoracic cavity within the mediastinum. Within the thoracic cavity, it's tilted to the left, where the apex of the heart is tilted just below the fifth rib. There are large vessels that enter and exit the heart. So let's start with the thoracic cavity. The thoracic cavity contains the lungs in the right and left pleural cavities. Between the lungs is the mediastinum. The mediastinum contains the heart, covered in pericardium, along with the esophagus, the trachea, and great vessels. Surrounding the thoracic cavity is the rib cage, which is connected to the sternum and thoracic vertebrae. The thoracic cavity is separated from the abdominal cavity by the diaphragm. Here's a more detailed image of the thoracic cavity from your textbook. It's important to learn the osteology, or the bony structures, to help to understand the surface anatomy that you can palpate on a patient. These are important landmarks for physical examination, and they are visible and palpable beneath the skin. We'll start with the clavicles. The clavicles are part of the pectoral girdle, attaching the upper limbs to the axial skeleton. The clavicles then attach to the sternum. The sternum is at the center of the chest cavity. The sternum is made up of the manubrium at the top, the body, and at its very base, the xiphoid process, which begins as cartilage and ossifies with age. At the top of the sternum, we have the jugular notch. You can palpate the jugular notch between the clavicles. Where the manubrium meets the body, we have the sternal angle, and that's an important landmark for finding the second rib. You'll also want to count down from the second rib to find the fifth rib. Both the second and fifth rib are important landmarks for listening to the heart valves. The ribs attach to the sternum by the costal cartilage. The costal cartilage at the base of the thoracic cage forms an angle, which is the costal angle. And the entire border of the ribs, including the costal cartilage, where the rib cage meets the abdominal region, is the costal margin. On the posterior side, you will find the thoracic vertebrae, particularly if you run your fingers down the back of your neck, you'll feel the spinous processes of the vertebrae, the most prominent of which is C7. Just below C7 is the T1 vertebrae, and you can then count T1 to T12 to find landmarks on the posterior side. We draw several lines down these regions to signify different areas of the body. We call these different mid-lines. So for example, drawing a line down the center of the sternum would be the mid-sternal line. We do the same thing down the center of the clavicles. The clavicles are not pictured here, but they would be attached just above the first rib here to either side of the sternum. So if you draw a line down the center of the clavicles, we have the mid-clavicular line, and other lines are similarly drawn. Here's a view of the surface anatomy landmarks with the skin, and you can see these different regions are very prominent on the thoracic cage. There are other lines that we draw in addition to the mid-sternal and mid-clavicular lines, and those can be viewed from the armpit region or down the side. The armpit region is the axilla, and so these are the different axillary lines. Down the center of the axilla is the mid-axillary line. Anterior to that is the anterior axillary line, and posterior to that is the posterior axillary line. These are important for descriptions of different regions of the body, but also lesions and different markings. Now let's look at the surrounding structures of the heart, the pericardium and the heart wall. So within the mediastinum, the heart is protected by an outer pericardial sac with pericardial fluid. It contains several layers of tissue that make up the heart wall. The pericardium is a double-walled, serous, fluid-filled membrane, which is often referred to as the pericardial sac. So when you open up the chest cavity, you'll see the lungs on either side, surrounded by the pleural membranes, which are also double-layered serous membranes. And then in the center of the chest, you won't actually see the heart. You're going to see the pericardial sac covered in pericardial fat. You have to open that up like a bag to find the heart inside. The functions of the pericardial sac are to prevent displacement of the heart as the heart is beating in the chest cavity, to act as a physical barrier against inflammation from the lungs and the pleural space, and also sensation. And we'll talk about innervation in a moment. The outermost layer of the pericardium, if we zoom in here, so let's look. So here's a slice of the pericardium, starting with this outermost layer here. So this would be making that outer portion of the pericardial sac. That's the fibrous pericardium. Just inside of that is the parietal layer of the serous pericardium. Then you'll have some fluid, which is the pericardial fluid, about 30 to 50 milliliters of a very thin serous fluid, and that's for lubrication. And then you've got the layer that's directly on the heart wall, which is the visceral layer of the serous pericardium. It's also called the epicardium. The pericardium has both nerve and blood supply. It's supplied by the phrenic nerve, which is C3, C4, and C5, and has pain sensation. This pain will refer to the top of the ipsilateral shoulder, or the shoulder on the same side. There is also innervation from the vagus nerve, but its function is unknown. Finally, we have innervation from the sympathetic trunk, which has a vasomotor function. And that is, it changes the constriction of the blood vessels supplying the pericardium. The blood supply is primarily from the pericardio-phrenic artery, and those are shown here in this diagram, which are lying next to the phrenic nerve. So below the pericardial sac, starting with the epicardium, we are now on the heart wall. So below the epicardium, we will then have the heart muscle, or the myocardium. That's cardiac muscle tissue, a specialized tissue for the heart. And then before you get to the inner chambers of the heart, where the blood will pass through, we have the endocardium. The heart is a double-sided pump. One side of the heart pumps blood to the lungs. The other side pumps blood to the body. The heart is also a blood reservoir. One side of the heart receives blood from the body, and the other receives blood from the lungs. If you combine the reservoirs and the pumping chambers, we then have 4 chambers within the heart. The chambers that go to and from the lungs are the pulmonary circuit. The chambers that go to and from the body, the rest of the body, are the systemic circuit. So let's start with the pulmonary circuit. The pulmonary circuit pumps blood to the lungs and returns blood from the lungs to the heart. Its purpose is to bring in carbon dioxide, oxygen-depleted blood, and replenish that with oxygen and remove the carbon dioxide. So the lungs will bring in oxygen and remove carbon dioxide. So the blood that pumps through the lungs will then be replenished and the waste will be removed. That blood will then return to the heart to complete the pulmonary circuit. The systemic circuit pumps blood to the body tissues and returns blood from the body tissues. We need to pump oxygen-rich blood to the tissues so that the tissues can carry out cellular respiration, and that is making energy, or ATP, using oxygen. In that process, carbon dioxide waste will be produced, and so the blood at the tissues needs to be returned to the heart with that carbon dioxide waste. In that case, the oxygen will have been used for the process of cellular respiration, so that blood will also be depleted of oxygen. That low oxygen waste-filled blood will return back to the heart where it can cycle through the pulmonary circuit. We'll understand this better if we look at the internal anatomy of the heart. So let's begin with the chambers. These are the areas that receive and pump blood, starting with the atria. We have a right atrium, which is the upper right portion of the heart, that's going to receive blood from the body. We have a left atrium, that is the upper left chamber of the heart, that's going to receive blood from the lungs. Between the atria, obscured by this large vessel here, which is the pulmonary trunk, between the atria, we have the interatrial septum, which is a bridge between the two. During development, there is a hole in the interatrial septum called the foramen ovale. When a baby is born and it breathes, the pressure gradient of breathing and the changes in the heart close that space, and it eventually becomes an indentation. Indentations we call fossa. So in the lab, you will see an indentation between the atria, which used to be a hole, and that is the fossa ovalis. In a small percentage of people, the fossa ovalis remains patent, but it has minor clinical implications. The lower chambers of the heart are the ventricles. The right ventricle pumps blood to the lungs. The left ventricle is the lower left chamber, and it pumps blood to the body. Between the ventricles visible here, you can see the interventricular septum. In order to get this blood in and out of the heart, we have large vessels. Entering the right atrium, the blood from the lower portion of the body comes in through the inferior vena cava. The blood from the upper portion of the body comes in through the superior vena cava, and you can see those openings here in the atrium drawn there. The right ventricle then pumps that blood out of the pulmonary trunk to the lungs. The pulmonary trunk branches to the pulmonary arteries. You'll notice that this is the only case in the body where arteries are colored blue in the diagrams, and that's because they carry deoxygenated blood before it gets to the lungs. Back into the left atrium, that blood that has just returned from the lungs comes in through the pulmonary veins. And likewise, this is the only case in the body where you will see veins diagrammed as red, and that's because they've just received oxygen from the lungs. So arteries move away from the heart and veins move towards the heart, and this is the only case in the body where we have deoxygenated arteries and oxygenated veins. From there, the left ventricle is going to pump blood out of this large vessel, which is the aorta. The aorta has an ascending portion, an arch, a descending portion, and then we'll move down through the thoracic cavity to have a thoracic aorta, and then down through the abdominal cavity to form the abdominal aorta. I'd like you to take a moment to pause here and review the structures that we just went through. So pause here and label the heart, and let's see how you do. Okay, did you do it? Check your answers and let me know if you have questions. Now you'll notice the structures between the chambers and large vessels of the heart. There are several valves that we need to think about. Between the atria and the ventricles, we have the atrioventricular valves, or the AV valves. These ensure one-way direction of blood flow when the heart is pumping. So between the atria and the ventricles, we have a valve. These valves must be open when the heart is filling, and they close when the ventricles are pumping, so that instead of the blood getting backed up into the atria, the blood will go out either the pulmonary trunk or the aorta. These are very powerful valves, and to prevent the valves from failing and going back into the atria, there are large collagen cords, which are the chordae tendineae. So when they say we have heartstrings, we really do. These are attached to the AV valves, and they're going to anchor the flaps or the cusps of the valve to the bottom of the ventricle wall. You can think of these like parachute strings, so that as the valves are closed, they prevent the cusps from flapping backwards. You can think about this in the same way as if you've ever had an umbrella fail on you. So the umbrella is supposed to stay nice and tight, but if it fails and it flaps backward, then you lose the direction of the flow. At the base of the chordae tendineae, there are muscles that are attached to the bottom of the ventricles. They're protruding from the ventricle wall and attached to the chordae tendineae. Their contraction is coordinated in order to hold the chordae tendineae tight while the ventricles are pumping. Here's a view of the AV valves when they're open and blood is filling, and when they're closed and the ventricles are pumping. So they prevent backflow of blood into the atria using pressure gradients. So as the pressure in the ventricles is low, the AV valves are open. The blood can then fill from the atria into the ventricles. Then when the ventricles pump, the pressure of the ventricle increases, and that closes the cusps of the AV valves to block the atria. With the atria blocked, the blood will then flow up into the large vessels, the pulmonary trunk or the aorta. So this is a nice view of what it looks like when the ventricles are relaxed and filling and the valves are open. And then here, the ventricles are pumping and contracting, and the blood is not going into the atria because the valves are preventing it. The blood is going out the large vessels. The semilunar valves also prevent backflow, but they're located in the large vessels. They're located in the pulmonary trunk and in the aorta. And rather than preventing movement upwards, they prevent movement downwards. So their cusps are located in such a way such that when the pressure in the ventricles goes down, they cup the fluid and keep it from backing up into the ventricles. That way the fluid continues out of the pulmonary trunk and out of the aorta. So here's a view of how they are when the ventricles are pumping and they're open. So they're allowing the blood to go through the pulmonary trunk and through the aorta when the ventricles are high pressure and pumping. Note at this point that the AV valves should be closed. And then when the pressure in the ventricle goes down, they will close their cusps and catch the blood so that it doesn't go backwards into the ventricles. These are called the semilunar valves because their cusps look like little half moons. This is a summary diagram from your textbook, which also shows the valves. And you'll see that when the ventricles are filling, the AV valves are open and the semilunar valves are closed. When the ventricles are pumping, the AV valves are closed and the semilunar valves are open. There are brief periods of time between these phases when both valves may be closed, and we'll talk about that in a future lecture as we kind of go through tiny details of how this relaxation and contraction occurs through the cardiac cycle. So just remember that in order for blood to flow from the atria to the ventricles, the AV valves must be open. And in order for the blood to flow from the ventricles out to either the lungs or to the body, the semilunar valves must be open and the AV valves should be closed. So if we summarize this, we can look at the pathway of blood through the heart. Blood's going to enter the heart through the superior and inferior vena cava and into the right atrium. It will then pass through the AV valve on the right-hand side, which is the tricuspid valve, and then enter into the right ventricle. Blood will be pumped from the right ventricle through the pulmonary semilunar valve to the pulmonary trunk and pulmonary arteries, and it will enter the lungs. Blood will return from the lungs through the pulmonary veins to the left atrium. From the left atrium, it will pass through the left AV valve, which is called the bicuspid or the mitral valve. And then the blood will enter the left ventricle. Blood will be pumped from the left ventricle then through the aortic semilunar valve to the aorta to get to the body tissues. And then from the body tissues, the cycle will begin again. The blood will enter through the superior and inferior vena cava and continue. It's really important that you get all of those structures down. So I'd like you to pause and draw the pathway of blood through the heart, starting at the superior vena cava and noting the pulmonary and systemic circuits. Okay, did you do it? Check your answers. Understanding the valves is important clinically. Valvular heart disease is due to problems with valve opening or closing, and there's many causes. In some cases, you'll have congenital malformation of the leaflets of the valves. Some patients will have a history of MI, or myocardial infarction, that can actually damage not just the myocardium, but also the papillary muscles and even the chordae tendineae. Atherosclerosis and calcification of valves with aging can also cause these effects. Trauma, infection, rheumatic fever, and infective endocarditis. These patients are very high risk, and the clinical consequences depend on severity, but can include dysrhythmias, ischemia, stroke, pulmonary edema, and heart failure. The patient may be unaware of these symptoms, or they may present with shortness of breath, cough, fatigue, dizziness, chest pain, palpitations, syncope, and heart failure. Much of this can be explained by either narrowing of the valves, which is stenosis, or incompetent valves, where they are regurgitant. Stenotic or narrowed valves make it difficult for blood to flow through the valve. In other words, they're high resistance and low efficiency. This can cause turbulent flow, and excess volume can be left behind. Mitral valve stenosis, the left atrium becomes overloaded and overstretched. In aortic valve stenosis, the left ventricle can hypertrophy due to the stress on the heart. You can also get inadequate coronary blood flow and ischemia. Regurgitant valves are the opposite. They are unable to close completely, and they're incompetent. Leakage or turbulent backflow can mean that less blood is ejected, or there's stasis of blood. For example, mitral valve insufficiency means that the left atrium can become overloaded and overstretched with the blood left behind. Listening to the heart is one way to listen for valvular disturbances. You can listen to heart sounds and heart murmurs, and this requires knowledge of the surface anatomy and the regions of blood flow. Changes in the heart valves are best heard not directly where the valves are located, but actually along the pathway of blood flow for each. The bicuspid or the mitral valve is best heard near the 5th and 6th intercostal space to the left of the sternum. That's near the cardiac apex. The tricuspid valve is best heard near the left lower sternal border. The pulmonary valve is best heard either to the lower left of the sternum or between the 2nd and 3rd intercostal space. This is numbers 3 and 4 on the diagram. The aortic valve is best heard between the 2nd and 3rd intercostal space to the right of the sternum. You will learn these areas of auscultation in your physical exam portion of your clinical skills course. Let's look now at the circulation and the blood supply to the heart. The coronary arteries branch from the aorta and supply blood to the heart itself. Beginning on the left side, branching from the aorta to the left side of the heart, between the atria and the ventricles, is the left coronary artery. The left coronary artery branches to the anterior interventricular artery. Surgeons like to call this the left anterior descending artery. It supplies blood to the left and right ventricle towards the apex and the interventricular septum. Another branch of the left coronary artery is the circumflex artery, which turns leftward around the left side of the ventricle. It supplies the left atrium, the lateral wall of the left ventricle, and the posterior surface of the left atrium and ventricle. So it curves around posterior, and you can see that here from the posterior view. On the right side, coming from the aorta, between the atria and the ventricles, is the right coronary artery. The right coronary artery has a branch down the right margin of the heart, which is the marginal artery, and this supplies blood to the right ventricle towards the apex of the heart. If we follow the right coronary artery posterior to the posterior side of the heart, you can find the posterior interventricular artery. Surgeons like to call this the posterior descending artery, or the PDA. This supplies blood to the posterior ventricle walls toward the apex. It is common to have variations in the coronary arteries. In particular, the posterior interventricular artery does not always originate from the right coronary. Sometimes it originates from the left coronary. After the blood has been delivered to the myocardium, the cardiac veins will return the blood back to the right atrium, just as all the other veins ultimately return blood to the superior and inferior vena cava to the right atrium. There are three major veins to know: the great, the middle, and the small cardiac vein. The great cardiac vein runs along the left side of the heart with the left coronary artery. The middle cardiac vein runs near the posterior descending artery, or the posterior interventricular artery, on the posterior side of the heart. And the small cardiac vein runs along with the right coronary system. Each of these three large cardiac veins will drain into this area here, which is on the posterior side of the heart, and that's the coronary sinus. There's an opening to the coronary sinus, from the coronary sinus to the right atrium, where that blood will be returned to the heart. Here's another simple diagram of the coronary circulation. Take a moment to review these. One note is that collateral arteries are possible in the heart, as they are in many locations in the body. These are connections across multiple arteries that create sort of a circular blood flow and additional blood flow pathways. When you have arteries joining together, these are called anastomoses, and that is the joining of two blood vessels. You can have anastomoses of veins as well. Here we're talking about the arteries. Particularly in a heart that has had a history of ischemia and shear stress, there will be collateral vessels that develop over time. They are protective then against further ischemia. The mechanism is that the shear stress due to blood flow occlusion activates growth factors and cytokines to help develop these vessels. While we're on the subject of the coronary vessels, I'd like to touch briefly on acute coronary syndrome, which is ischemic heart disease. Acute coronary syndromes are a range of ischemic heart diseases caused by a lack of blood flow, particularly lack of oxygen to the myocardium. There's many causes of this, for example, atherosclerosis in the coronary arteries, obstruction of the coronary arteries through thrombi, vasospasm of the coronary arteries, even anemia can result in inadequate oxygen delivery to the myocardium. This inadequate blood supply, for example, during exertion, can lead to anaerobic metabolism and increased adenosine and lactic acid. That can lead to temporary ischemia, lack of circulation then, and risk of reperfusion injury. Angina pectoris is chest pain caused by lack of blood flow to the myocardium. In some patients, this is stable. In others, it's unstable and can be a medical emergency. Prolonged lack of oxygen to the heart can lead to death of the heart muscle tissue, and that is then an infarction. If it occurs in the heart muscle, it's a myocardial infarction, an MI, or a heart attack. Cardiac muscle is similar to skeletal muscle, but it's specialized to allow the heart to have long, sustained, and coordinated contractions. Just like skeletal muscle, it has many mitochondria, and it is striated, meaning that it has a sarcomere arrangement to its actin and myosin proteins. These are the contractile proteins within the muscle cells. Heart, however, requires much more extracellular calcium than skeletal muscle, and we'll talk about this when we get into the physiology of the heart. Actin and myosin are the contractile proteins, and they require calcium and ATP. Troponin and tropomyosin are regulatory proteins located on the actin filaments. One note here is that there's a specialized form of troponin in cardiac muscle cells. And this is a useful lab test for myocardial infarction because if the cells are damaged, the myocardium cells specifically, then cardiac troponin can be used to detect that damage. Intercalated discs contain gap junctions between the myocardial cells. And this creates a functional network of muscle cells, cardiac muscle cells, that all respond in a coordinated fashion to electrical activity. We call this a functional syncytium, where groups of cells are connected together and responding together. Here's a view of the myocardium and a reminder of what a sarcomere arrangement looks like when you have troponin and tropomyosin regulating the actin, and the actin and myosin forming dark and light bands of the muscle tissue. When we talk about cardiac physiology, we'll talk about the importance of specializations in cardiac muscle. We'll touch on them briefly here. Cardiac and skeletal contractions are very different. There is no recruitment in cardiac muscle. This is very different from skeletal muscle, where skeletal muscle can recruit additional motor units to increase the strength of contraction. Cardiac muscle needs to act in a coordinated fashion, and it needs to be reliable and forceful. So contraction is all in due to these gap junctions, and the strength of contraction is modulated instead of adding motor units activity. It's modulated by the stretch of the heart wall. We'll talk about that when we talk about the physiology. There's also no tetany or no max sustained contraction like there is in skeletal muscle. And that's because the heart needs to both fill and pump, and fill and pump. You wouldn't want tetany to occur in a heart muscle. So instead you have a very long refractory period in heart muscle, and we'll talk about that later too. Cardiac muscle also responds in a different fashion. Some of the cardiac myocytes have been specialized to form autorhythmic electrical cells. These are embedded within the heart wall, and they send electrical pulses through the heart. So you don't need outside nerves to get the heart to pump and fill. In other words, the nervous system does not cause the contractions of the heart. Of course, the nervous system can modulate and modify the contractions of the heart, but the heart can beat on its own, completely independent. So the heart is independently excitable because of these autorhythmic cells. The nervous system can regulate heart contractions, and I'll show you that in a moment. These autorhythmic cells are called the intrinsic conduction system. They are self-excitable and do not require outside nervous system activity. This is the anatomy of the intrinsic conduction system. Starting in the upper right atrium near the superior vena cava, we have the SA node. Those pacemaker cells then send branches to the next portion, which is the AV node. SA stands for sinoatrial. AV stands for atrioventricular. This is near the right atrioventricular junction, close to the opening to the coronary sinus. The AV node then sends down activity to the bundle of His. This is also called the AV bundle. The AV bundle splits into right and left bundle branches down the interventricular septum, and then small fibers, or a network of fibers, are sent from the apex through the ventricle walls, and those are called the Purkinje fibers, or the subendocardial conducting network. The myocardium is innervated. The intrinsic conduction system of the heart drives the contraction, but there is also external innervation of the heart, and this is done by autonomic nerves. Autonomic nerves supply the organs and are involuntary. This is in contrast to the sensory and motor spinal nerves, which are voluntary and conscious. The sympathetic trunk of the autonomic nervous system, T1 to T4 spinal nerves, increase heart rate, increase the force of contraction, and dilate the coronary arteries. There are pain fibers that are located within the myocardium, but they're not actually pain. So we can't think of these in the same way that, for example, we think of the pain traveling through the phrenic nerve of the pericardium. This is not direct pain, cold touch, or temperature sensation, but it's actually a metabolic sensitivity. And that is when there is ischemia and metabolic factors that are released due to ischemia of the heart. That can cause specific referred pain to the T1 to T4 dermatomes. We already talked about the C3, 4, and 5 dermatomes of the phrenic nerve. Here's a visual of where that referred pain would be due to pain in the pericardium. The T1 to T4 spinal nerves would refer pain to these regions here. Again, this is a metabolic sensitivity of the myocardium and not specifically pain. There's also innervation to the heart through the parasympathetic nervous system, through the vagus nerve or cranial nerve 10. This will slow heart rate, reduce the contractile force of the myocardium, and some studies have shown that it can also constrict the coronary arteries. One final note before we end is about chest pain. There's some current research that suggests that we need to think about chest pain a little bit differently than we have in the past. Chest pain is the most common symptom reported in cardiac ischemia, and this group of syndromes is the acute coronary syndromes. But 35% of both male and female patients do not report any chest pain with cardiac ischemia. This means that there's a risk of missing the diagnosis if you're only looking for chest pain. Those who did not report chest pain reported symptoms of weakness, feeling hot or flushed, shortness of breath, cold sweats, and pain in the left arm or shoulder. So that pain in the left arm and shoulder is actually pericardial referred pain. Women also frequently report, in addition to those symptoms, back pain, nausea, neck and throat pain, right arm and shoulder pain, and sometimes jaw or tooth pain. So it's important to think about chest pain as not the only symptom of acute coronary syndrome, and it's also important to consider that male and female patients may present with cardiac ischemia in a slightly different pattern. Okay, I hope this was helpful. Let me know if you have any questions.